The WHA has a long history of determinations from 1996 to the present, which established violence as a leading worldwide public health problem. The advancement of resolutions regarding violence is striking in many regards, but perhaps most significantly in its identification of health system actors as critical change agents and its emphasis on women, girls, and children. World Vision contributed to the development of two key guidance documents in 2016, the Global Plan of Action to strengthen the role of the health system within a national multi-sector response to address interpersonal violence, and the Inspire guidance for 7 strategies for ending violence against children. Both of these documents highlight the need to address violence against children in a multi-sectoral way, and both also point to the leading role that health systems and health actors need to play to both address and prevent violence against women, girls, and children. World Vision was a proud supporter of the development of this year's WHA Resolution 74.17 on ending violence against children through health system strengthening and multi-sectoral approaches. Sadly, since the earlier WHA resolutions, interpersonal violence against children has not decreased. Violence affects an estimated 1 billion children with many early, acute, and lifelong intergenerational consequences. We must invest more in ending violence against children. First, because this violence puts children at an increased risk of delayed cognitive development, mental health conditions, high risk and health harming behaviors, and further interpersonal and self-directed violence. Secondly, we must do more because we can do more. Morality must march with capacity. Following on these decades of warnings and resolutions and the tragic experience of millions of children for whom violence was not prevented, we must assume responsibility for ensuring improved systems and services to protect them. World Vision is committed to a multi-sectoral approach to ending violence against children, and I wanted to briefly talk about 2 different ways that we're doing that. First, aside from our advocacy and technical support for the WHO guidance and resolutions, we made the decision recently to train the 184,000 community health workers with whom we work in the identification and referral of children who are experiencing violence. Earlier research that we did in 4 countries with hundreds of community health workers found that about 3/4 of CHWs reported observing violence against children in their work, and 3/4 thought that violence against children was a serious problem. While most CHWs believed it was already part of their role to prevent and respond to violence against children, only 1/4 of them have received any training on violence against children. So we're changing that through training. Secondly, World Vision is scaling a project model that can have a big impact on violence against children called nurturing care groups. NCGs are a multi-sectoral version of the highly effective care group approach, which has been scaled by the Malawi Ministry of Health. It is used to promote parenting behaviors that are associated with most elements of the nurturing care framework, which was released by the WHO and UNICEF in 2019. This model promotes basic parenting skills and adoption of key behaviors from most sectors, not just health, nutrition, and WASH, where care groups have traditionally been used, but also child protection and early child education, where it has been used less often. We're testing it for improvement in caregiver mental health as well. And faith leaders can also be trained to reduce violence against children through this model. Henry Perry, who is a world expert on CHWs, and I believe that if we want to scale up the nurturing care framework and the Thrive agenda, we need to have more and more countries using 2 tiers of community health workers. The current tier, who often work a few days a week or full-time, and eventually they should all be paid, and a second tier of volunteer community health workers who can focus mostly on behavior change with limited hours, about 8 hours a week or less. Without these 2 tiers, we don't see how we can address all of the things that we need to address without severely overloading community health workers, including violence against children. We recently tested this NCG model in Ghana over 15 months using a quasi-experimental design that reached about 14,000 households using over 1,000 volunteer community health workers. That project focused on reduction of harsh punishments of children and WASH behaviors. We found that parents who were reached by the NCG volunteers, when compared to those who lived nearby but did not, were less likely to use 8 different forms of physical violence against their child, more likely to often or always praise a child in 6 specific ways, and more likely to know and practice parental relaxation techniques. And in a separate cluster randomized controlled trial in Uganda, we found that caregivers who were reached by this approach had a 95% decrease in depression as well. Caregivers who were reached with the nurturing care group model were also less likely than controls to say that punishment that they give depends on their mood. They were more likely than controls to often or always do 8 different positive things with a child, such as asking them about school, homework, and friends, and inviting them to help play in family activities. One great thing about this model is it's not solely focused on ending violence against children, so it enables integration. It's a behavior change platform, and government ministries can use it to accomplish other goals in WASH, education, health, nutrition, and cross-cutting concerns such as gender. For example, this slide shows how clean drinking water, hand washing, and penning of animals increased 24, 50, and 20 percentage points in the intervention group in the Ghana Nurturing Care Group project, which, as I remind you, was only 15 months long. The controls, meanwhile, showed no improvement or worsening in these same indicators over the same time period. The care group approach, upon which this model is built, was found to have 53% better reduction in child deaths than other community health worker models as well. And all of these great reductions in harsh punishment of children were actually carried out by WASH staff, not child protection staff. All of this was achieved at a cost per beneficiary per year of about $3 US. The training of community health workers in identification and referral of children experiencing violence and the use of nurturing care groups are just 2 examples of the actions that need to be taken in the health system. Ending violence against children requires similar assessment and action at every level and among all actors. In World Vision, we hope and pray that government ministries everywhere will keep this year's resolution at the front of their universal health coverage agenda and become the champions and leaders for ending violence against children that they need to be. Thank you.